已經夠人啦，咁有8
members. We have formed a quorum, there are 8 of us, and we have also got Mr. Pun Siu-ping, so we can start our meeting. Well, this is a meeting of the panel on health services. If need be, you can go to the Home Affairs panel to help them form their quorum. Mrs. Regina Yip made a request to hold a public hearing on the development of Chinese medicine. But it's somewhat risky to hold such a hearing in July and August. So perhaps let's do it in October. Welcome, Secretary. We are still on some in-house matters. Item 2 on the agenda now. Matters arising. At one point, we talked about rare disease policies. We thank the Secretary for a very detailed study report. So the idea is to conduct an overseas duty visit, and members please consider where we should go. And in October, we can make a report to the House Committee. The earliest day to embark on such a visit would be in December. So members, please consider whether we should go and to where and who should participate. And should we also invite LegCo members who are not panel members? So you may want to digest this document first before we have a follow-up discussion. As far as I can remember, I can recollect the proposers of the visit are not here with us now. So please consider where we should go if we are to go on such an overseas duty visit. Third item, Hong Kong strategy and action plan on antimicrobial resistance. We've given you this big document and some papers. Welcome, Secretary, for your first attendance at our panel meeting. Thank you. As the Chairman said, since I assumed office in July, this is my first attendance of the meeting of the panel on health services. As you may be aware, that we are tasked to promote public health and the provision of healthcare services through interdisciplinary and the introduction of a comprehensive policy to make sure that we have a dual system of both public sector and private sector healthcare services. And also we would like to improve quality of service in the public sector. So there are important measures to address. Since I have assumed my office, we have to look at some urgent issues about manpower shortage, workload, long waiting time. And we're now also having 4 pieces of legislation under scrutiny. We also want to promote community health and also control chronic diseases and the development of Chinese medicines, and also to reduce the demand for the specialist services. And we would like to cooperate with the Council and with all sectors of the community to take forward our proposal. Coming back to this item on action plan, strategy and action plan on antimicrobial resistance, let me highlight some of the contents. together with the relevant departments representative and colleagues from the HA, I would like to brief members on the strategy and action plan. Antimicrobial resistance is a major public concern because it makes microbial existence make it difficult or more expensive to deal with infection-related problems or for patients recovering from operations, and in some extreme cases, such conditions are not treatable. According to WHO, annually speaking, 700,000 people die because of microbial resistant related problems, and also the incidence rate of problems caused by microbial resistance is 2 to 3 times that of other diseases. If we don't come up with a effective action plan, we expect that 10 million people would die by 2025, causing a total economic loss of $100 trillion. UN and the and also the WHO of the view that bacterial with antimicrobial resistance can spread over national boundaries, and so we need to mobilize cross-sectorial involvement to take action collectively to reduce or low down the spread of antimicrobial problems.
The government is always concerned about the problem of AMA and also the threat posed to public health. We have implemented various measures at different sectors to stop the spread or slow down the spread of AMA. In 2016, policy address, a high-level steering committee on AMR was set up with representatives from government departments, public and private hospitals, healthcare organizations, academia, and relevant professional bodies. So together they will study and formulate strategies and action plans. Under the steering committee, an expert committee on AMR has been set up with representatives from both Hong Kong and overseas. There are people with expertise in different areas, and they would give expert advice to the steering committee on various aspects and also epidemiologically based strategies. On the One Health framework, the steering committee has given regard to the WHO's One Health framework, and so a 5-year holistic action plan was set up to cover 6 major areas with 19 objectives, hoping to slow down the emergence of AMR and to prevent its spread. Through surveillance and research, information will be enhanced and to improve the use of antibiotics on men and animals, and through various measures we will prevent infection and will make use of effective publicity and promotion to enhance public awareness of this problem and to support studies in this area and to participate in global collaborative research activities. In principle, the high-level steering committee endorsed the plan and was launched on the 10th of July 2017. AFCD, Department of Health, HA, and also the SH, the Food and Health Bureau will keep a close eye on international development and will liaise with public and private hospitals and also the academia to roll out a series of actions laid down in the 7 key areas with 19 objectives to implement the action plan. The public health and veterinary partners must work very closely. This 5-year plan will receive an interim and final review, and where necessary, it will be amended and extractions will be added to cope with the latest situation in Hong Kong. Thank you. I will be happy to receive questions from members, and relevant parties are present to answer members' questions. Thank you. We have 3 members, Dr. Wong, Ms. Alice Mack, and also Mr. Poon Chiu Ping. Dr. Wong, thank you. Regarding Hong Kong strategy and action plan on AMR, it is long awaited, and earlier on I approached members of the steering committee. The DP supports the government's efforts in regulating the use of antibiotics. We've been too slow and too late in taking action, and therefore urge the administration to act as expeditiously as possible. Otherwise, we won't have any antibiotics available to treat infections. So I have a few questions. Regarding 1.3, develop AMR surveillance program in animals. I understand that there have been proposals. If in farms, if antibiotics are to be mixed with animal feeds, or the purchase of antibiotics must have the approval of veterinary surgeons. First, I'd like to know whether this is going to be implemented. And I think this plan is about local farms only, whereas a lot of our fresh produce is imported from the mainland. So for registered farms in the mainland are supplying meat, pork, poultry, and fish to Hong Kong, what animal feeds do they know? If they have their own system, then it's useless if we tackle our own farms properly, because chilled poultry and other food produce are from the mainland. Of course, if they are not registered farms to supply fresh produce to Hong Kong, we have no control over them. But for farms that supply fruit products to Hong Kong, will we ensure that these farms follow our regulatory framework in the use of antibiotics and animal feeds to ensure that they comply with our system? If it is one country, 2 systems, then no matter how hard we try, we will still have the problem of AMR. Thank you, Dr. Wong, for your question. In our 6 key areas, one is to enhance our relationship with our partners and to engage stakeholders. So both human and animals, both humans and animals are our concern. And I think what you propose will require legislative amendments, but I can invite AFCD to provide the details. And for food supply, I can invite a Center for Food Safety to respond. Thank you. Thank you, Dr. Wong. Regarding antibiotic use being used by our pig and poultry farms, well, when animals are sick, Usually, the farmers will come to consult our vets at AFCD when antibiotics are called for. We'll give them a permit, and they can use the permit to purchase antibiotics to treat their animals. We're going to tighten the system. We hope that within 2 years' time, farmers will consult their own vets, which will give them prescriptions for buying antibiotics before they can be used on animals. So will legislation be required? Currently, it is not needed. What about farms, registered farms supplying food produce to Hong Kong? Dr. Choi, speaker is off mic. Yes, please switch on the microphone for Dr. Choi. As said by Dr. Wong, much of our fresh produce comes from the mainland, including pork. Our arrangement with the mainland is such that for meat for human consumption, we have a piece of legislation to regulate the level of pesticides or animal residues, animal drugs residue. Some drugs are banned altogether, and the standard is just the same as what we have in Hong Kong. And I think there are drugs already specified in our local legislation and the maximum level allowed. The standard is just the same for fresh and chilled meat imported from the mainland as well as other countries. The standards are just the same. And as Mr. Dr. Sid said, in the coming 2 years, or anyway, their target is to introduce new measures in the coming 2 years. Will we discuss with the mainland on the permitted levels of animal drugs residues in meat? We will discuss with the mainland. In fact, the mainland is starting to be concerned about AMR just like us, and they've also got a 5-year guideline. A lot of it is similar to what we are considering. They also have a plan and also targets for the coming 5 years. So this is the situation. In due course, we will discuss with them once again. So it's just like the residue of animal drugs, veterinary drugs in animals. I want the government to ensure that our standards are consistent or compatible with that of the mainland, so that our steps will be synchronized. Otherwise, there may be the problem of AMR. Dr. Wong, this item is on that strategic document from the mainland. We've invited the FHD representatives to come. So for the amount of antibiotics and veterinary drugs found in our meat, perhaps we can discuss it in the HSP once again. Because today we are talking about a strategy. It's not that I don't want to give you time, but if you want to talk about chilled and frozen meat, I think we can defer to a later stage so that we can have a more detailed discussion. Ms. Alice Mack. Now for the strategy and action plan, we cover both animals and humans. I think it's easier to deal with animals. After all, it's about surveillance and regulation. Whether you are confident in the government's enforcement efforts is a separate issue. But for use of antibiotics on humans, I think it's a bit more different. Now, for everyone many people who see a doctor would think that the doctor is excellent if he can cure you with one dose of medicine. So public education and publicity are very important. For instance, to tell people to complete a program of antibiotics treatment or to refrain from using it. I think our liberal studies can include this.
We have to remember that we also have a member of our family who is called domestic helpers. So we should provide information to domestic helpers. They are helping us to care for our children or our elderly people. They give medicine to our elderly family members. And something that certain medicines should not be taken if there's no fever. I opened the fridge lately, and then I found a lot of medicines, and the domestic helper also act as the domestic dispenser. And don't also forget the ethnic minorities in our publicity. There should be different languages used in our publicity material so that they are informed of such public health we all are concerned about publicity and public education. In the use of antibiotics, we must exercise proper control. Healthcare workers are, of course, the key users, but we also need to allow our people to gain a better understanding. The Department of Health has got some work to do to promote awareness on AMR. For example, the DOH has a Clean Hand Day campaign annually. Apart from healthcare workers, vets, and people working in the food produce industry and animal husbandry industry, the other groups that are mentioned by the member will also be covered by such publicity efforts. Would you prepare leaflets in languages of ethnic minorities for distribution to them? I believe that they would pay particular attention to two groups that you mentioned. First of all, domestic helpers, and secondly, the ethnic minorities. I think the DOH will pay attention to this. Mr. Poon Siu Ping, according to the Secretary, there are 6 key areas and 19 objectives in the action plan, and there are a number of ongoing initiatives. And they will do this in 2017, 2018, and 2019. The DOH, AFCD, CFS, FHB, professional bodies, and FEHD will all be chipping in. Of course, I would like to support this action plan but I need to know something. Promote research for innovation on medicine, diagnostics, and related intervention, and to understand drivers of resistance, including local research. Of course, it will be under the D of H and people working in the healthcare system. Will the government provide additional resources for this? And also under 3.22, there's a suggestion on it. A data collection on dispense and also to collect information, monitor microbial use in humans, collect dispensary data from HA. Is this coverage sufficient? Would that affect the accuracy of data? Are you going to ask private medical practitioners to do this voluntarily or what? Thank you for your question. First question is about the provision of resources. I think whatever you do, you need resources. If we look at the timetable and the objectives, we know that there are some ongoing activities. Of course, for their new initiative, and we will strive to get more resources to tie in the work in this regard.
至於私家醫生嗰度咧，
private doctors, on private doctors, on how doctors dispense antibiotics is a major concern now. According to WHO reports, we'd like to exercise control or to promote the correct usage. I think Dr. Zhang from the HA can say something about this. Our colleagues at the D of H has also got some programs to disseminate information to private doctors so that they can know how to correctly use antibiotics. In our HA, we have a computer system to monitor the use of antibiotics. I think the member was asking about private medical practitioner, doctors in private practice, that is. At present, this is done voluntarily on the part of doctors in private practice. So can you really reflect the true picture from such data collected from doctors? So you HA doctors, of course, would heed your advice. But what about private doctors? Well, we have something under the action plan to collect procurement data from pharmacies and pharmaceutical companies, or to reflect the usage of antibiotics by doctors in private practice, so that we can monitor the overall usage of antibiotics, and also consider the feasibility of using electronic health record to capture prescription data from private doctors. Dr. Pierre Chen. Thank you. I thank all the officials for coming here. And I'm still reading the electronic version of reports. This is the third or fourth time that I have encountered such a problem. It's okay. I can read the e-version, because after the panel meeting, there will be no opportunity for me to pursue further questions. It's my question. I know there are reports. According to my pager, the report will be in my office on Friday. I note this, but I would like to just point out that this has happened more than once.
犯法嘅問題。咁我見到咧。
I have a question about misuse or abuse vis-a-vis illegal use. So we are said doctors can prescribe antibiotics, but now we have a problem with abuse. There are news report saying that some parties use a lot of antibiotics to make the feed better. So it's against the law. So on the one hand, you talk about abuse by doctors, and on the other hand, illegal use is not properly tackled. So how do you define abuse for the animal or farm operators and doctors? Abuse by doctors and farm operators. You talk about flu-like symptoms, and it said that no antibiotics should be prescribed. So my question on this is that it's difficult for me to differentiate. Let's say there's a patient with fever and some flu-like symptoms. I cannot tell apart how I can differentiate the different symptoms of different diseases, pneumoconiosis, malaria. They all show similar symptoms. I don't know how to tell them apart. But if I don't use antibiotics, I may be accused of delaying the prescription. So as a doctor, I find this difficult. If I prescribe it, it's an act of abuse. If I don't, it may be delaying of a proper prescription. I may be accused of delaying a proper prescription. Yes, I can say something, and then I ask the head of the Health Protection Center for Health Protection, the controller, to say something. I think both we and the WHO would like to make sure that antibiotics are used when it's appropriate to use it. And there are guidelines for healthcare providers to know under what circumstances antibiotics should be prescribed. So proper use is the subject of something specific in the guideline. As for the one of flu-like symptoms, maybe I can ask Dr. Wong to say something about that. Thank you, Dr. Chen, for your question. Please switch on the microphone of Dr. Wong Ka-heng on the use of antibiotics. Hong Kong makes reference to the WHO and other international authorities' recommendations. To tackle AMR, we should act with prudence, and also we should not use it excessively. This is an important guideline, a direction for all of us. We have the DOH has initiated a program to direct the use of antibiotics at the primary healthcare level. We know that hospitals have been doing this for a long time, but in the primary healthcare setting, we have also started this program together with professional bodies, private doctors, organizations. We are starting to do this. We'd like to come up with some clinical conditions which would warrant the use of antibiotics. It's in the form of guidelines. We hope that colleagues can make better judgments in deciding whether to use antibiotics. But I understand, I agree that each patient may be different. It it may have to be assessed clinically by the doctor, particularly when you are not supported by other medical checks. So clinical judgment will be even more important if this is the patient's case. And sometimes time is of the essence, and you may need to prescribe antibiotics. If the patient shows fever and sore throat, then there's a scoring system adopted by some other countries. I think Dr. Chan knows this, but not all doctors are familiar with this system. We have a scoring system so as to ascertain symptoms and carry out some tests, and the final score would indicate whether for this particular patient there are bacterial infection requiring the prescription of antibiotics. This would be helpful, but at present not all doctors are well versed about this. So we would like to do a better job along this direction in providing support. And then we can talk to private doctors to see whether after the promulgation of guidelines things showed improvement. We can all do all these. Chairman, with your indulgence, may I say that there is a document, a set of guidelines, evidence-based document on this subject.
Now, for layman, I heard the term professional clinical judgment, whether antibiotics should be prescribed for flu-like symptoms. I think if you have such protocol guidelines, please let the relevant member have it, because time is limited and we may not be too conversant with it. So from what I gather, you mean that doctors should have the professional judgment to decide when antibiotics should be prescribed, and with the guideline, doctors can be assisted in making that decision. Dr. Kwokake, I agree with you, Chairman, on the doctor concerned has a great responsibility in making a decision. I think both doctors and patients are now more wary as to whether antibiotics should be prescribed, and that once you have started, you must complete the full course. Half of the antibiotics are being used on animals. I think for local farms, we know that a lot of food is from the mainland. So if the guidelines are just for local farms, is not good enough. So can we, on a regular basis, inspect registered farms on the mainland? That is, can surprise visits be conducted? And then for meat imported from the mainland for Hong Kong, I think we should test for the existence of antibiotics more frequently. And for the AMR bacteria, most of them are from hospitals. We know the conditions in our hospitals are very serious, and the beds are 130% full as at today. Well, according to your guidelines, beds should at least be 1 meter apart. But we heard that at public toilets and even at staircases, if you can have a bed, then you are very lucky. So I'd like to know, when will the government be decisive enough to tackle this problem, and that can be by addition of beds, expansion of hospitals, so on and so forth. Because if you don't do that, everything is just empty talk. And community dispensaries, they are selling antibiotics illegally. The situation is serious. From time to time, we have patients coming in with lots of medication, claiming that it's from a local chemist, not prescribed by the pharmacist, but just supplied by a local chemist for treating inflammation, so on and so forth, because the Department of Health is not patrolling enough. So even if you have control over the HA hospitals, clinics, and private hospitals, it's useless, because if you don't control the community pharmacies. So what strategies do you have? Thank you. For food supply to Hong Kong from the mainland, can I invite the Center of Food Safety to answer? I'd like to talk about the hospitals. Dr. Kwok, you said that you referred to the problem of overcrowdedness in hospitals. As we all know, we have expansion or redevelopment plans of hospitals. In between beds, we have to ensure a certain separation, a certain distance, so as to control infection. But for hospitals and wards that have yet to be redeveloped, HA is aware of their situation and is considering what can be done given the situation we have. And of course, observing good hygiene and infection control measures are just as important. Perhaps the Department of Health can talk about inspection of community pharmacists. Do you have surprise checks? We do liaise with the mainland. Poultry and animal farms in the mainland are patrolled by us. We inspect about 50 of them on a yearly basis. And as for surprise visits, I don't think this is possible yet, because we do not have a jurisdiction over these farms, so we have to rely on the relevant authorities across the boundary to make arrangements for us. Dr. Kwok said that we should test for veterinary drugs in meat from local suppliers. In the past 5 years, we have tested for antibiotics in meat in about 25 samples in 2015-16, and only one sample of live chicken from Hong Kong has exceeded the permitted level. And what about inspection of community pharmacies? We inspect those pharmacies on a regular basis. We have tests, purchase, operations, we have surprise checks, and so forth. The Department of Health attaches a lot of significance to the impact of AMR by these pharmacies. And so under 4 area for objective 4, we strengthen regulation on over-the-counter purchase of prescription-only antimicrobials. So we have enhanced inspection for pharmacies that have purchased or procured large quantities of antimicrobials. We can enhance surveillance and inspection of these pharmacies. Test purchase would also be done more frequently. Through these measures, we hope that we can crack down on such practices. The Department of Health has also done a survey to ask whether antimicrobials consumed by patients were prescribed by doctors or purchased at local pharmacies. The percentage from the latter is very low. Still, we will enhance public education. Can you give us statistics on the number of inspections? In between 2016 and 12 and 16, Department of Health inspected 6,060, made 6,060 inspections. There were 50 cases of prosecution under Cap 137 antibiotics ordinance. In 15 cases, there was conviction. Thank you. Mr. Yu Siwing. The purpose of the strategy and action plan is prevention, surveillance, and public education. And you have some criteria to assess the situation. If the situation is worse than you expected, what will be your strategy? Will you have further steps to improve the situation? Thank you, Mr. Siu. Under the 6 areas and 19 objectives, we have measures to tackle the problem. We have also got strategic interventions. So we have to consider the timing and also the objectives. In the interim and our final review, of course, the interim review is more important. If in this review we identify inadequacies and unexpected results, we will enhance our action. We'll see whether more resources should be granted, or maybe within the planned time frame we might not have completed or may not have achieved the objective. We'll see whether the time should be lengthened. But if after a review it is found that we cannot achieve our desired result, we will see how we can improve the situation. And long-term surveillance is also important, because this will allow us to see whether we can achieve our intended objectives. And in public education and publicity, if our measures are effective, then there will be enhanced awareness among the stakeholders and also the public. Mr. Yu, well, there isn't enough deterrent effect. Are there overseas practices we can learn from to enhance the deterrent effect to avoid abuse? Our communication with stakeholders and publicity and education will be strengthened. Different objectives will be dealt with in a different manner. Well, you have made 6,000 odd inspections of local pharmacies, and yet there were only 15 convictions. What is the basis for your prosecution? If it is not a registered pharmacist, if it is just an ordinary member of the public, or just the anyone other than the pharmacist, who should be penalized? The pharmacist, or the operator, or the or what? Usually, the name of a drug is written on the prescription pack. If people take the pack to a local pharmacy to purchase drugs, can the pharmacies just give it to, well, this will not do. There must be a doctor's prescription. But this is happening. I think if you have I think if you want the pharmacist to give you a controlled drug, there must be a doctor's prescription. Chairman, you're correct. If you would like to purchase antibiotics, you must have a prescription. And such drugs can only be sold in the presence of a registered pharmacist. Dr. Wong can supplement. Dr. Wong. I think of details of the 15 cases of conviction. But for all cases, it depends on the evidence. We have to consult the DOJ to see whether prosecution should be taken. But under our surveillance, most antibiotics can only be sold with a doctor's prescription. Now, if we have questions on food, such as chilled poultry, meat, I suggest that we tackle it in the panel on food safety and environmental hygiene, because we still have 2 more items. If members do not mind, we extend the meeting to 6:45 because I believe the other 2 agenda items will attract a lot of attention as well. So we will end the discussion of this item here. And the second item is enhancement of medical fee waiver mechanism of hospital authority.
Thank you.
I'd like to
welcome the second team from the administration, and this is an item on the enhancement of medical fee waiver system of HA. Members may wish to put questions over to the PS for an introduction. Good afternoon, members. This paper briefs members on the recent enhancement introduced by the Hospital Authority to its medical fee waiver mechanism. You know that our public healthcare services are heavily subsidized, and to uphold government policy that no one will be denied adequate medical care due to lack of means, the HA has put in place a medical fee waiver mechanism to provide assistance to needy patients. Recipients of CSSA are already waived from payment of public healthcare expenses for those non-CSSA patients who cannot afford the medical fees. So, for example, those suffering from serious or chronic illnesses, HA has a mechanism in place for them to seek financial assistance from medical social workers stationed in the public hospitals. The medical social workers will assess the applicant's eligibility for a waiver. For the assessment criteria, the social worker will look at the total monthly income and the family assets of the patient. If the applicant cannot satisfy the financial criteria, the medical social worker can also provide a waiver for special cases. For example, because of family problems, they can ask for a waiver. On the 18th of June, the HA introduced revisions to fees and charges. At the same time, they also further enhanced the waiver system to protect the needy from being affected by the new fees. the first item is to redefine the household definition, having regard to views from the public and also other financial assistance schemes. We have reviewed and amended the definition of household, which will only cover core family members such as the spouse, children, parents, and dependent siblings. Other relatives, even living together under the same roof, will not be considered as coming under the new household definition. And also further relaxed criteria for granting period waiver with duration of 12 months. At present, for outpatient services, we can provide the period waiver. And if the patient has to regularly use hospitalization services and A&E services, we can also grant the 12-month waiver. The third measure is to relax the asset limit. The original asset limit of the waiver mechanism was set in 2003 by the HA by making reference to asset limit under CSSA at that time. In order to protect the needy from being affected by the new fees and charges, the HA, having regard to the latest asset limits under CSSA, has introduced some relaxation to the asset limit for the waiver mechanism. And HA has also revised the asset calculation of property. If, for example, HOS, threat for sale scheme will not be calculated in the asset of the patient if they are uncompleted threats. And on the 15th of July, that is last Saturday, the fee waiver system has been extended to the OALA recipients aged 75 or above, or age 65 or above. All they have to do is to show their ID and the relevant certificate, and the fees will be waived. We estimate that 140 elderly persons will benefit from the arrangement. Our HA representatives and I are happy to take questions from members. The floor is now open for members. We have 3 members who would like to ask questions. Dr. Fernando Cheung, 5 minutes. Regarding medical fee waiver. It has to some extent to do with the recent revisions to fees and charges, such as A&E and clinic fees. So although the government may not admit it, this enhancement has to do with the recent fee increases. It said that with a higher fee, the demand on A&E services can be contained. So please remember that the demand is really there, and don't try to increase the fees to deter patients. I hope the government and the HA would conduct a review into this. I think you have a very harsh definition on household for members of families living together. You cover 3 generations. If you live with your parents, then your children, you yourself, and the parents would be covered in the asset and income calculations. I think around the world, we don't have any means test which would cover 3 generations in the family. We have been saying that this is not appropriate for many years. I think the most appropriate is to cover just the couple themselves and not the children and parents. I know it's difficult to make a drastic change. What about covering 2 generations instead of 3 at least. And if you cover 2 generations, and if we are talking about an elder who's already retired and has some savings, let's say he's 65 and he has some MPF accumulated for retirement, and if you take that into account in the calculation of the patient who is his son, so what do you mean? What do you want? Do you want them to spend all the money, or to spend the money on his son for medical treatment, and then when they all get poor, they would just apply for CSSA? This is not very ethical. Why do we have such a system? Can you also examine all retirement fund related assets? So 2 questions. Definition of household members, and second question, retirement benefits. Dr. Zhang, I think Dr. Zhang's question on the question on fees, fee increases. Well, it's only introduced recently, and then we have this flu outbreak. So it's difficult to assess at this point the impact on Category 4 and Category 5 patients. We need more time, and then we can make a comparison with the service demand before and after the introduction of fee increases. We would conduct the review regularly on the definition of household or family. I would like to have something that is appropriate in the Hong Kong context. This review has resulted in the narrowing down of the definition to respond to public views. For example, brothers, sisters, or cousins, they will be exempted even if they are living together with the patient. As for the question of taking into account 3 generations, if there are more family members in the family, the relevant criteria will also be different. So in the amount of waiver, if one is a breadwinner and the other is not working, then we'll provide a higher amount of waiver. But of course, under different circumstances, the different sets of family members would give rise to the different computations and implications. What about discounting the retirement benefits? We haven't handled this yet. Maybe we can take this on board in the next review. Well, this is unreasonable. I hope you can do this urgently. When would the next review be conducted? When you increase fees next time? Well, actually, we are going to review our fees and charges every 2 years, once every 2 years. Mr. Poon Siu Ping, if the patient cannot meet the means test criteria, the medical, the social worker can provide us special waiver if warranted and under a discretionary scheme. From 2012 to 2013, the number of approved waiver applications for non-CSSA recipient dropped from 2012-13. That is from 28,054 to the 22,774 in 2016-17. Why are the figures dropping over the years? And also, how many of them are had their application rejected? And I also support the extension of the waiver to always LA recipient age 65 or above instead of 75. Have you assessed how many people would benefit from the arrangement? Let me take the second question first. This is what we have done in response to a call to improve elderly benefits. That is providing a fee waiver to OALA recipients age 75 and also the elderly person age 65 who passed the means test. As regards the number of approved waiver applications for non-CSSA recipients, I will ask Ms. Chung of the HA to respond to that. The number of approved cases in 28,000 in 2012 and 22,000 in 2016. So the question is, are we being harsh? But over the years, we have enhanced our arrangement. For example, we are approving more cases under the 12-month waiver arrangement. So although the number of cases has dropped under this category, but the number of recipients of waiver have not dropped. In the past, they had to apply 3 or 4 times a year, and now we are approving more cases under the period waiver arrangement. So the number dropped mainly because of the extension of the period waiver system. We don't have any figures on the rejected application and the number of rejected cases. And I have to also mention that this is both about financial criteria and non-financial criteria. Very often, the medical or social worker can also exercise discretion to approve waiver on non-medical, non-financial grounds, and we also provide one-time waivers as well.
So you don't have statistics on cases rejected. So you have 20 or 1,000, maybe 20, 30,000 applications have been rejected. Well, we don't have such statistics with us. But usually, if they come to apply and if they have special reasons, the social worker may grant discretionary approval and consider whether there is other information on the financial situation. If there are cases rejected by our medical social workers, usually it is after examination the applicant withdrew the application because they consider themselves ineligible, and we do not have statistics on cases rejected because very often the applicant will not come back. So the applicants do not apply to you directly, rather it's through MSW, right? And therefore, if after seeing the MSW they decide not to apply, you won't have that data. Yes, Mr. Shukajan. First, I want to thank the HA for heeding our advice. They have relaxed the criteria a bit, so I want to thank you for that. But for the asset limit, I'd like to ask more questions. Now, it is fixed at 75 medium monthly household income, but for elderly persons, because they won't have any further income, they are given positive discrimination, and therefore the asset limit is a little bit higher. How come for OALA it is fixed at $140,000, and you have covered those who are 75 years old to $144,000, but for families with elderly persons, the allowance is raised to $168,000 for each elderly member. Is it that for elderly persons not eligible for OALA, they have to face a higher threshold? Well, in SWT has got two tiers for OALA, those who are older and with less asset. So when this measure was formulated, we took on board suggestions from Labor and Welfare Bureau and SWT. Under the system, we should help those who are older and with financial needs first. For the young old with more asset, that doesn't mean that they cannot apply for a medical fee waiver. Their cases will be handled under the current HA mechanism. If the applicant is a chronically ill person, then he will be given period waiver with duration of 12 months. So this is for dealing with younger olds with more asset. So you blame the Labor and Welfare Bureau and the SWT. I don't think this is necessary. HA can make its own judgment. There is no need for you to have two different asset limits, because those OALA recipients have to face a higher threshold. I think this is already a good thing. I think you should rectify the defect to make it even better. Yes, when we review the mechanism, we'll reflect your views. Thank you. Mr. Ray Chen. 12E, to extend medical fee waiver to OALA recipients aged 75 above with more financial needs. An elderly person came to my ward office asking me to reflect his case to you. So, all right, those older OALA recipients with more financial needs, that is those over 75 above with asset not exceeding 144,000, will be given a certificate so long as they can provide the ID and the certificate. Then they will be waived in the future. But the elderly person is already 75, and he find it rather burdensome to bring another medical fee waiver certificate. What if he is already at the hospital and finds out that he has forgotten it? So should he go back home and return afterwards? So why can't you pass on his information to the HA? I know currently you cannot have sharing of information, but once this is done, then HA only needs to verify the ID card of the elderly person concerned, and he won't need to bring the waiver certificate. So this is a question and a request made on his behalf. We have taken this into account, and this is already done. There is a linkage between us and SWD's computer system. So if an elderly person tells us that he has got the waiver certificate but he has just forgotten it, we can check with SWT. If he has the certificate, all the best. So the case would not take longer time. No. Oh, then many elderly persons are not aware of this, and some of them might make a trip home purposely to collect the certificate. So please publicize to elderly persons. Thank you. I'd like to follow up on Dr. Fernando Jones' question. Why are assets are calculated on a household basis and not on a personal basis? In fact, for the social welfare sector has this consensus. Elderly persons should be allowed to apply for CSSA on a personal basis and not a household basis. So can you please take note of this? HPA, can this be considered? In Hong Kong, we have different safety nets, whether it be legal aid, education, or CSSA, or medical health care. The criteria might be a little bit different. Of course, there are also common elements. Most of our social net system has been designed on a family basis, hoping to promote a self-help among family members. Should there be a change in the policy, we may consider changing our arrangements. But for safety nets, we will make cross-reference of other systems. But when we apply for different allowances, always asked to apply on a household basis, but this has created lots of disputes in families. There can be conflicts between sons and fathers and two generations and so forth. Well, if there is a family conflict, we will consider other non-financial factors. MSW has the discretion to approve cases even though the financial criteria are not met. Ms. Chong. Yes, applications should be made on a household basis. That's the reference. But if in a case the family relations is not very good and the children may not be able to support the elderly person, then there can be discretion made by the MSW. I just want you to give our MSWs a break. You know, they are already very busy. If they have to be gatekeepers as well, then this is really very difficult. Yes, I also hope that elderly persons don't have to use this mechanism, because it would be best they don't have to be hospitalized. And if they do, as said by Mr. Shield, please do not increase the workload of MSWs. Dr. Kwokaki, to be fair, if we have a system that cannot help people who needs it, then it's useless. So you have to consider the income of 3 generations. Then I think you are driving them away. And if you take into account benefits from MPF, I think you're ensuring that they cannot get help, because your system cannot help them. And some of them do not need just outpatient follow-ups. Some have to receive a chronic inpatient treatment. And you also take into account medical appliances such as artificial joint, so on and so forth. That means their possibility of getting assistance is very, very low. I've asked you to review it a lot of times, but you say that you have to wait for 2 years. Then, because the threshold is so high, many people have exceeded your asset limit. You know, you will talk about savings by elderly persons for their future funeral. So it's $380,000 for a family of 1 elderly. unless we talk about people living in destitute. Otherwise, well, this money is savings for their future funeral or for really urgent matters. For instance, if the person lives in old building, then a maintenance and repair exercise can cost hundreds of thousands of dollars. It's just like the operations building bright. People have to pocket a lot of money. Now, it would be more reasonable if you consider an elderly couple a single unit, because you know, the younger generation may not be able to look after themselves. How they have to repay grant and loan. How can you expect them to look after their elderly parents? This is different from CSSA recipients. These people do not have any incentives. The money cannot be pocketed. So medical fee waiver is different from cash assistance. So can the administration be more sympathetic? We're talking about hundreds of millions of dollars, hundreds of billions of dollars in spending in other areas. So can you give them a medical fee waiver? Can you give us a reply earlier so that we don't have to wait for 2 years? P.S. or HA, I understand your concern. We have to consider how we can benefit some families. If we further tighten the definition of household definition, some families may even be worse off. Now we will discount siblings living under the same roof. Now for siblings living under the same roof, it's likely that they have income. But if we discount them and consider other people, we have to see whether they have income.
Or if they are dependents, let's say the elderly mother of the family and mother of family have retired and no income, they have no income. And if a family has more family members, the limits will be higher. So unless all the family members, the spouse and the parents all have jobs, then the asset limit will be very difficult to satisfy. So if the couple are both working, and if they have to support the parents, the elderly parents and some siblings, then perhaps they can enjoy a bigger waiver. So if we further narrow the definition of household, then we may cause a backfire. But I hope that with the enhancement, things will be better. Well, exclusion of siblings may be better, but not necessarily if we exclude children. Dr. Helena Wong, I welcome this enhancement arrangement for HA fees. Under 12E, the fee waiver is provided to ALA recipient age 75 or above, and those over age 65 or above who pass the means test. You expect that the 140,000 elderly person will be benefited from the arrangement. If we further lower the age limit from 75 to 65, how many more elderly persons will be benefited, and how much additional resources will be needed? Another member has asked a similar question. We do have the information, but it's not with me. We can provide it later. I hope it can be provided as soon as possible. The Democratic Party would like to see the age limit lowered to 65. Many people have to retire at 60 because their employers would ask them to leave. And if you say that they have to wait 15 years before they're eligible for fee waiver, or when they reach 65, they have to pass a means test. So some of them may or may not be able to cope in the interim. So we like the age limit to be lowered from 75 to 65. Well, this is an additional arrangement. They don't have to apply to the HA for fee waiver. If they have a specific needs, they can always apply to the HA. The HA would assess such applications based on the means test and the asset test. So it's just that OALA recipients age 75 will automatically be entitled to the fee waiver. They don't have to apply to HA. For those age over 65 or above, would you remind them that they can apply through some channels? It's not automatically approved. How can you make sure that such information is provided to the elders concerned, and that they can use a streamlined procedure to apply? Actually, it's not just for those, for people over 65. Anyone in need will be informed of this arrangement. We would give wide publicity to the fee waiver arrangement. If they are in the hospital, when they do the registration, they will be provided with the information. And also we work with patients groups, and we will also disseminate information when we visit elderly homes and send service centers for the elderly. So that elderly people will know that they can apply if they have needs. Do you have any figures on the number of application of those over 65 and they're under 75 who have applied in the past few years? Do you have any figures to tell us with regard to those over 65 but below 75? Dr. Fernando Chiang, there was a question about the number of approved waiver applications for non-CSSA recipients, and the number has been dropping over the years. And the explanation offered is that we are talking about number of cases, number of applications. Previously, people applied a number of times, and now they need only to apply once. Can we have the number of patients involved, the figure on patients involved? We're talking about the number of times. There's no need to explain. Just tell us the number of patients. All right. So this subject is about the HA fee waiver. And we have had a round of discussion. We now move on to the next item. This subject that we have discussed on a number of occasions and is now being revisited. And the item is on provision of public dental care services. We have had many rounds of discussion previously. I don't know whether the the PS has sent. The permanent secretary has got anything new to say. If not, we can save time and proceed to the Q&A direct. While the officials are being seated, members can raise questions. In theory, this meeting should end at 6:30, but we can extend it to 6:45. As I've said, This is a much discussed subject. We have read the paper, so we proceed to the Q&A direct. 5 minutes for each member. 2 members would like to ask questions, Dr. Kwok K and Dr. Fernando Zhang. 5 minutes, Dr. Kwok. The chairman has said that this has been discussed a number of times, but nothing has come out of it. And the Audit Commission has published a report. Many dentists would like the government to do more, to provide more for people who are not benefited under the existing schemes, for example, mentally handicapped, disabled, low-income people, and those people who are not assisted under the CCF or the CSSA. They are not able to afford dental service. We're not talking about scaling, but implants or denture, so that they can have teeth to eat. We're talking about tens of thousands of dollars. If we're talking about a number of denture, we're talking about up to $100,000. They are not in destitute as to warrant the CSSA payment. And we're talking about the elderly people with serious dental problems. And there are elderly people queuing up at 4 or 5 a.m. and if they're lucky, they get a service on the same day for tooth extraction only, and there's nothing following that. Since we are wasting a lot of resources, for example, the unused appointment slots. What can you do to respond to the Audit Commission's criticism? And can you improve upon the inhumane system? You're not asking elderly people to queue up at 4 a.m. or 5 a.m. Do you have a better arrangement? For example, you can just give them appointments, for advance appointments, and they don't have to queue up every day. And the government should come up with a policy on all these things for people who are not in a sound financial position, but their income is not as low as to be eligible for CSSA and also for CCF. Some are not eligible, and for the mentally disabled children, you got only some one-off schemes. And in the children's hospital in Kwun, would you set up a new dental service unit for the disabled persons, 17-year-old, 18 years old, 19 years old, with IQ equivalent to 6 or 7-year-olds? So can we have something more in the long term, and instead of one-off schemes? I'll ask the Department of Health to respond to the Audit Commission's comments on how the resources can be better utilized. At present, we need to concentrate our limited resources on education and the promotion of good oral care, good oral health. And we also provide dental care to the students so that the habit of proper dental care can be established from a young age. I also note the members' suggestions that we need to provide services to elderly people in need, and the people with disabilities, and we do provide dedicated programs to assist them. And we also provide public service for dental urgent dental needs. And we have also applied from the CCF funding support for elderly dental assistance for low-income elders who are not eligible for CSSA regarding services to the disabled. There was a pilot scheme for the disabled. It was much welcomed by by persons with disabilities. Therefore, we will continue with this program, and it would be expanded so that more the persons with disabilities would have access to this service. And we need to get more professional dentists with professional training to serve the disabled. So we'll train up more the dentists to provide services to the disabled. We are reaching the final stage of our discussion. In the next legislative session, we will be ready to brief members on the initiative. And now I would like to ask my colleagues from the D of H to say something about the improvement to our dental care services. Dr. Lam would be the speaker. Thank you. The Audit Commission's report refers to unused dental appointments. In the 11 so-called outpatient clinics, 3 of them register unused appointment slots. For example, Typo Dental, 74.7%, Changzhou, 50%, Kennedy Road, the Dental Clinic, 25.2%.
To enhance the utilization rate, we have enhanced the publicity of the Kennedy Town Clinic. We send out pamphlets to encourage people who cannot get a slot in other clinics to attend that dental clinic. These measures, together with the Kennedy Town MTR station, the utilization rate has greatly enhanced. In 2016-17, unused chips have reduced to 34%. We believe this will continue to drop. For the utilization rate of the 2 dental clinics in Taiwo and Changzhou, because they mainly serve the residents on these 2 islands, they are more remote and it's difficult to attract people from other districts to travel to the 2 dental clinics. So we'll maintain the services of the 2 dental clinics. We'll continue to monitor the utilization rate and conduct a review in due course. And as for the elderly persons, we have considered different measures. In fact, the services, outpatient services are limited. Once we've registered them, what service capacity is even smaller. So we have yet to come up with services to help the elderly. And for the elderly persons, perhaps it's easier for them to queue up for a slot. So will you expand the public-private sector cooperation scheme just like the HA for the disabled and the low-income persons? Can you encourage them to use private services? We'll discuss with the Bureau. In particular, services for the disabled will certainly move towards this direction, because you cannot really employ dentists quickly enough to fill the gap. Well, we've already got the CCF, and we've also got the outreach dental services for the elderly. We will consider how we can do more and enhance our service on this basis. Dr. Fernando Zhang, of course, my greatest concern is services for people with disabilities. Let me declare interest. My daughter faced a similar situation. It's very difficult for her to see a dentist. Many private dentists do not want to treat them because the procedures are more complicated. They need a few nurses to restrain them, and sometimes GA is needed, and this is not possible in ordinary dental clinics. For the Dentalian program is well received by most parents, and towards the end of the program, because of the calls from parents, the government decided to extend it for another year, but no new cases would be accepted. So we've been waiting for a long time to see how the administration is going to do with this program. All right, we hear this afternoon that you may extend it, but you have no special plans yet. And then in Hong Kong U, we do not have a special dentistry branch. In fact, all over the world, there is this dental specialty, but we don't have it in Hong Kong. So what is the government's position? We encourage our universities to start a special dentistry branch. And can you give us a specific plan as soon as possible? Because currently people cannot be admitted. You will only deal with the 1,000 or so cases in your backlog, but the queue out there is very long, and for the elderly, they also suffer. They've been telling us that for civil servants, they have a full range of dental services, but for the elderly persons, what about taken up slots of civil service dental clinics? You will only provide tooth extraction services. So I think the solution is simple. If you're willing to provide more chips, more treatment slots, and if you can expand the range of services to cover more, of course, as CCF has covered some elderly persons, but only up to 10,000 odd for a time being. There is less than 1/10 of the sector of population requiring such services. So can you have further improvements for dental services for the elderly and the disabled? You can consider giving dental care voucher schemes for the disabled. With the Prince of Philip Dental Hospital and also the Hong Kong University, we have discussed whether professional or specialist training can be provided. In the long term, we should set up a special branch of dentistry. However, we do understand the services for the disabled cannot be stopped, and we will train a group of dentists ASAP so as to ensure that there is no disruption of services in this regard. So this is our urgent task. We will extend services or expensive dental services for the disabled. We want more dentists and dental organizations to join so that they can be given appropriate training so that they can start to provide service ASAP. We hope that in this legislative session, in this legislative year, we can. Are you talking about this or the next So you talk about this within the coming 3 years? No. I am talking about the session after the summer recess. I hope they will be able to confirm the training and provision of service arrangements. That is to give us a report in October, after October. Services to the public in our dental clinics. We will follow up with the Department of Health. If we can secure more resources, we would like to improve current services to see whether more resources can be provided to people who have urgent need for dental services. We will try to do that, but that depends on the availability of resources. Because every year we're spending close to $60 billion in different aspects of medical and health care. Of course, we want to see indefinite increase in resources, but that is not possible. Still, we will secure more resources to improve current dental services to the public. When can you give us a specific plan? Well, perhaps you give us a specific plan and also a timetable later. For improvement of current services every year, we have the resource allocation exercise within the administration. We will report to members following the allocation of resources exercise. Is it possible to provide dental voucher scheme for children or for the elderly? Para 15 tells us that the elderly health voucher scheme can cover dental services, and the eligibility age is lowered to 65 years old. Now, we welcome this. On the one hand, it offers more flexibility, but the problem is once an elderly person makes a visit to a dentist, he need not see a doctor during the same year because dental services are very expensive. Perhaps you can double the amount to 4,000. Of course, it is for the elders concerned to decide whether he's going to spend that money on dental services or on medical services. Yes, it is a bit difficult because elderly persons have a variety of needs. So do we need a special health voucher scheme to specify a specific area of needs? We have to consider this. The current scheme allows flexibility in the use of health vouchers. Dr. Hannah Wong asked whether we can increase the amount of vouchers that can be brought back to the administration for further consideration. Dental services is not dispensable when it comes to the elderly. Many elders have come to complain to our council because if they don't have teeth, they cannot eat. So this is not something really dispensable. I hope the administration can study this seriously, and dental services for our primary school children, as well as dental care for people with disabilities. According to a paper, they are quite popular. But why is it that for primary school students, they are not so eager to join the service or the scheme? Is it because they're too busy, they have to prepare for TSA or go to tutorial schools and so on and so forth? And why can't you extend the scheme to cover even secondary school children, so that all those under 18 years old can join the scheme? Dr. Hui? Now for P6 students, well, with the consent of the school, schools P1 to P5 students will be given transport arrangement by the schools, and then they can go to our unit for dental checkups. So we give them time slots. For P6 students, we give them time slots outside normal school days so that they can make appointments themselves. We have reviewed the arrangement. Perhaps if we ask them to attend appointments, then maybe it is not very convenient. Their parents may not be able to accompany them, and so the turnout rate may be a bit lower. So we're exploring with schools who have joined the scheme to see whether we can have transport arrangement for P6 students as well. I really support this because obviously you have fewer P6 students attending appointments, so it's all because of traffic arrangement. Yes, we also have an internet system for school children. If students have registered to for the service, they will be given an appointment reminder. We hope that they can be more proactive in joining the scheme so that they can be given a reminder to attend an appointment.
How about secondary students? Well, after primary 6, the oral health standards are really usually high. We also have some publicity and promotion activities carried out in secondary schools, so that after primary 6 they continue to maintain good oral hygiene through such publicity and promotion activities. For the time being, we have not looked into any dental health programs for secondary students. We will monitor the situation for future planning. Mr. Xiu Ka-chun, thank you, Chairman. As you've said, we have discussed this a number of times. I remember I was sitting over there. The Undersecretary, Professor Sophia Chen, was over there. And all the questions raised sound familiar. This shows that this council is toothless. So we have had a number of discussions. We have passed different motions, but nothing comes out of it. So we may be toothless. I don't want the elderly people to be toothless. According to the UN standards, an 80-year-old should have 20 teeth, not counting denture. I don't think the government would adopt such a standard which you are not going to fulfill. But there are worldwide standards. 20 real teeth for an 80-year-old is the lowest limit. And I won't repeat points about how important oral health and dental health is to the elderly. And I also want to explain the relevance of food and health and the Labor and Welfare Bureau. We have the latest elderly care program. It said that there should be more community service so that elderly can get services in their home. And you all know that the dental care services for adults are very inadequate. They only provide extraction and not other services. There are only a few quotas, so that elderly people aging at home cannot do so. So would the government improve the outpatient clinics for dental care services, so that the elderly can really can really age in place? And so don't tell me that this is something for the Labor and Welfare Bureau. Can I get a response along this line? The Audit Commission's report has already said that we should review our policy on dental oral care. We will make reference to international practices and come up with a proper, a formal oral hygiene objective and oral health objective. The Department of Health will also be working on this. They conduct regular surveys that they would, having regard to local circumstances, come up with an objective for oral health. What is the current objective? I would defer to my colleagues from D of H. 20 teeth for those over 80. At this point, we don't have this objective for those over 80. Turning as regards the Audit Commission's recommendation, we set up an expert group to set an objective for Hong Kong. The 80-20 from the WHO is not for all countries in the world. They understand that the different countries have different circumstances and they are allowed to set their own objectives. So we would review this objective under the expert group. Do you agree that the 80-20 objectives should be achieved or exceeded in Hong Kong, and we should do better than that? With the regular surveys which are conducted every 10 years, we don't cover anyone over 80. Of course, we hope that we can maintain the good oral health for those over 80. So in the coming oral health survey, we will consider covering those over 80. When can we expect a report from your expert group on the review? We'll set up the expert group first. We're going to invite professors on public oral health in the University of Hong Kong. Well, if you have set up the expert group, please provide us with the papers, and when the report is ready, please brief us. I don't know whether I will still be in the panel. Okay, do we have to wait for? Is it not going to be available in 3 years? I don't know. So, but we'd like to have the opportunity to see the report. Mr. Ray Chan, every year when we scrutinize the budget, we would talk about the same problem. If they have oral health problem, if they may also be suffering from other medical conditions such as indigestion and so on. I know some elderly people would have steel dentures when they visited the mainland because it's cheaper over there. And Dr. Helena Wong wants you to increase the amount of medical voucher to $4,000. But I would rather to have a dedicated dental voucher scheme, because many elders are most reluctant to spend money under the voucher scheme, they will not only see a doctor when it's absolutely necessary, because they don't know whether they are going to fall sick in a major way next month. And if you don't have scaling and you have a tooth decay, it won't kill you. So they don't use the medical voucher for dental services. They would reserve the voucher for future medical care. I don't know whether the government has kept statistics on how many people are using the voucher on the dental services. So I would like you to have another dental voucher scheme for scaling and dental services. Otherwise, they would not care, even if they have a problem. I'm not saying that you should have dedicated voucher for all sorts of organ, but the problem with medical and healthcare voucher is that elders are reluctant to use it on dental services. So perhaps you can conduct a survey to see whether they will support providing them, the idea of providing them with dental voucher. I know the members from different political parties, Democrats or not Democrats, have proposed this idea of a dental voucher scheme. We have heard members, we will look into this, but I believe that the resources involved will be tremendous. So we need to look at the sustainability as well. Apart from outpatient services, through different programs, we also provide the elderly with some other services, such as the outreach dental services and the CCF supported dental services, dental assistance program for the elderly. We can certainly look into ways to enhance these programs or whether to increase more services. All these will be looked into. How many elders have used the healthcare voucher on dental services? I don't have the statistics. Can you tell us to what extent the medical voucher have been utilized by the elders on dental services? I'll check if we have got the data after the meeting. Well, this has been put on the agenda a number of times. We are concerned about dental services for children and elderly people and people in need. According to the Department of Health, they are going to set up an expert group to look into this. We'd like to see how it goes. So that concludes this item. We don't have anything under AOB. This is the last regular meeting under the current session. Thank you all for your participation. See you all after the summer break. Thank you.